Hi again. It's Granny Jenny from middle of Nowheresville, America. In her pillowbilly state, I'm back in my basement. My cat has banished me to the basement. Apparently, she's kind of a little bit just kind of sick and tired of my salty language, all the words that are coming out of my mouth as I'm reading stuff. And so this alley cat who thrived maybe a couple of years on the street before she was rescued can't even tolerate the words coming out of my mouth. Now I'm going to give you information on baby B, and this is part 2. Would encourage you to watch part A to kind of understand the background on that and on this baby. And we're picking up here where the baby was transferred to and his sister, baby B, was transferred to the intensive care unit and overnight. I'm not seeing anything where anything had happened kind of from the 8 p.m. to the 8 a.m. Situation. Just as a background, do remember that mom, and no one's aware of that, has a history of APS, which would put the baby at a very high risk for clots, and a history of lupus, which would put the baby at a very high risk of having cardiac issues. What I'm noticing on this baby here, and I'm noticing is a common thread on many of the babies, that they're too focused on the feedings. Even one of the parents has even noticed that. One of the moms that had a baby that had to go back and forth from Liverpool to the Countess of Chester, that Liverpool Women's Hospital, it was like night and day. They were really good at so far as trying to get the baby off the oxygen and getting on, it's thriving that way, where the Countess of Chester, their only focus was on the feedings. And again, while that is important, again, they're getting their eyes are off the ball here. And as I just do take note that there is a feeding research going on by the research is the name of SIFT, and I kind of explained that in my previous video. Do take note that I believe that this baby is running out of gas, out of energy, out of glucose. It's premature. It does not have the brown fat that you would normally have that would be able to kind of provide a lot of the energy sources. It doesn't have that good storage, glucose storage and energy storage in the liver because it's just too premature. This baby has been through a traumatic birth, a traumatic resuscitation. There is filth everywhere. There is an severely infected baby that is probably inches away from that. I am convinced that they are keeping these babies too cold. Another common thread I'm seeing with many of these babies is that they were allowing them to get cold, and that is bad. When a baby gets cold, it uses up so much energy. That energy cannot be used for important bodily functions. So lo and behold, this baby is now, we're going on to Monday, the 8 a.m. shift. And that's, unfortunately, it was assigned to a nurse that I'm not very fond of, and I believe is very lazy, and a nurse that clearly, through her testimony, threw Lucy under the bus. And I believe she threw Lucy under the bus in order to protect herself. And not to show what really poor nursing care she gave. I also do believe that this nurse has a thing for Lucy, has a thing out for her, and does not like her. And unfortunately also that the baby now has that registrar that I don't like. The one that likes to make sure she gets home on time and really, really drop the ball on baby C, which is a baby that died from a severe obstruction, and who I am confident had the most painful death out of all these babies. In her testimony, she threw Lucy under the bus to protect her career, and currently she is a neonatologist at Liverpool Women's Hospital. I don't know how. I think she gave that testimony and threw Lucy under the bus just to save her own career. Now, no one's aware of mom's history, that babies could be throwing clots here or heart arrhythmias. And importantly, both the baby A, the boy, and baby B The twin sister only have little peripheral lines here. That's the only line they have, and they're very, very high risk babies. And they should have probably something that's a little bit more substantial so far as an IV, or at least a second line, and they do not. But luckily, they are getting sugar to some degree. But during the day shift, what's kind of going on, and again, that lazy nurse is not noticing that the respirations are going up. That's a clear sign the baby is probably getting what we would call acidic, trying to blow off carbon dioxide in an attempt to stabilize its pH of his blood. It's extremely important that that happens. Baby is have, since it doesn't have the sugar, it's under severe stress. It's unable to use like a good fuel source, which would be a sugar. It has to probably avert to some sort of other fuel source, and the byproduct of that is acid. The ABGs, which is the arterial blood gases, those are showing that the baby is not doing well. They're not bad, but again, there are signs there. And this would be the nurse, she's actually drawing these and charting these and putting those in, and she's not noticing on that. And again, and also there were a lot of temperature readings that she did not do during the day too, that are missing, and that's vitally important. Now, Ben Myers during the trial is noting this, what's going on here, and she's saying, oh, nah, yeah, it's a little bit concerning, but not really too much. It just really doing, again, a common thread. It's almost like the dead parrot skit from Monty Python. Just bizarre. Totally. And she keeps using the word stable. And that's really bad. Granted, this is the first baby that the jury heard about. And when your own nursing colleague is saying, no, this was a stable baby, the jury had to take note. Not only Dewey, the consultants, the parents, but when your own colleague does it too, that had to have had a significant impact on the jury. Now, another thing that we found out is that she made a mistake during this whole thing, and there's a Dadex on her that she gave an extra dose of caffeine she should have had. She did a drug error on this baby. Now, I'm wondering, why is this baby on caffeine, and why is she giving it an extra dose? I'm thinking, and the only reason you give caffeine and maybe overdose the baby is that this baby's having apnea, and she's not documenting it too. And so maybe it may not have been a mistake after all. Maybe one of the registrar told her to do it, and she's not owning up to it, I should say. Now, okay, and another common theme I'm seeing is that these registrars, consultants, they're spending too much time on the pediatric ward and not nearly enough time on the neonatal intensive care unit. They should be assessing these babies first and then go into the pediatric ward. Instead, they're doing the exact opposite. It's as if that neonatal intensive care unit is just, something to the side, and we'll just let these junior doctors take care of it. We'll handle the pediatric ward. Ravi is here at this time. He is in the clinic. Okay, he's still there. That registrar that should have been assessing this baby and keeping an eye on it, no, she's doing whatever she needs to do in the pediatric ward. And basically the only doctor that is here is that poor junior doctor that's with her, that kind of that first year that really doesn't know a whole lot and doesn't have a whole lot of experience. But Ravi is, again, another common thread I see is that he'll just phone it in. He'll just call him and tell him what to do instead of showing up. And that pediatric ward is just a few feet away. I don't know what it is. He just doesn't seem to want to kind of go through a door and look at these babies. Now, again, and this is the registrar that kind of wanted to go home that I had talked about earlier. And Ravi is telling them, as he should, this baby needs something called a central line. And that would be, what they would do is it needs to have a vessel, a line in a vessel that's big enough that can handle pretty heavy duty IV fluids, pretty heavy minerals and stuff, and fats and stuff that you would need to survive. This baby is too premature in order to tolerate anything that's being put in its gut. It couldn't absorb it. So what they do is essentially get all your nutrients and all that important stuff. You get it through an IV that's a bigger blood vessel that can handle this too. So he tells her, okay, you got to put in a UVC line, and that's just a line that you would put in through the umbilical cord, and you put that line through, and you're able to kind of snake it up into a large enough vessel that could handle it. Now the issue is, and it's very important, that when you snake it up, you don't let it branch off into some very important blood vessels. And unfortunately, this snaked into a very, very important blood vessel kind of area that we would call the portal vein area. That's a really, really important series of blood vessels that's being sent through the liver. And the liver is think of it as an incredible filter. This is like blood that's shunted, that's when we absorb things through our intestine, it goes through through this blood vessel, and it goes to the liver, so the liver can kind of filter it. So it's again, it's a bypass. Everything has got to be both filtered through, and eventually it'll go back to the heart where it'll be pumped through. Unfortunately, there's no really direct line to the heart. That's real important in this, and they know they have to take this line out, which they do. And Ravi tells the registrar to put it back in, and instead of her doing her job or doing it with alongside her first year trainee, kind of to help that person do it, she tells the trainee to do it. And this is the first year, and the trainee, too inexperienced, she does it again, and she even has to do it and figure out a way to do this and snake it through. You have to go kind of through the portholes of the incubator, which kind of makes things just even more difficult in order to snake this through. And again, it ends up in that very important liver vein. Now, lo and behold, 4 o'clock comes along, and then that tiny little IV that baby has, it's getting a little bit of sugar. It infiltrates, or tissue, you call it tissued. And I'm really thinking with this lazy nurse that again, usually when an IV infiltrates, the signs don't happen a lot of times right away. It takes a little time for that sign to show up. So I'm thinking it may have even stopped working even before 4 o'clock. So this baby is now going on several hours, at minimum 4 hours, if not, I would imagine 5 to 6 hours, essentially with no sugar. All right. Now, again, that registrar wants to go home during the day, and she basically then has to pass on to the evening and the night registrar, who's even worse than her so far as doing stuff. In fact, so bad that he is implicated in about the first half of these babies here. It's usually he has an involvement with it, and it's just sad. And his testimony at the trials on several of these babies, it was clear, like this other registrar, he was trying to save his career, and he knew he messed up bad time. And the fact that he messed up so bad with this baby, I'm shocked that the consultants weren't keeping a good eye on him and saying, okay, we got to kind of pull back. And I do believe he might have even been at something as high as a 4th year. So his skill levels, were really bad. So not only now he has to put in what we call a long line on this baby. You don't want to put another umbilical catheter into this baby. There's just too many risk factors in it. So now you got to put a line in, and usually they put it in here in this arm, and they're able to kind of snake it up into an important and big enough blood vessel so it can handle all these important fats and nutrients and everything. The issue is you got to make sure you don't get it too close to a blood vessel that's close to the heart or even into the heart itself. That could trigger things, trigger certain nerves and trigger certain things so far as the heart is concerned. It's not a good sign. But he has to put in 3 of these lines on 3 of the babies. I think there are 3. I don't think there's 4. I think there's 3 babies in the intensive care units, and every single one of them, the lines were lost, and that all should have been done, or at least some of this should have been done prior to this, though, that registrar leaving, but she kind of leaves it to him. And putting in these lines, again, you have to do it under a sterile situation. You have to gown and glove with sterile stuff, and it takes a while. It's a procedure on that. In addition, this poor registrar not only has to cover this and cover the neonatal intensive care unit, but he has to cover the pediatric ward, and if there's any children that show up in the A&E too. So it's going to be a really bad and busy night for this gentleman. And all he has to help him is a first-year training, I think, as a GP, a very inexperienced, and again, not a pediatric trainee, but a GP that's just in there for just a short period of time to get some pediatric training. Now, we do believe he puts the line in sometime around between 5 and 6:45. Again, the documentation on this and what the both Ravi, the consultants, and the junior doctors put in, we'll just say it's sketchy and needs to be gone through with a fine-tooth comb, which it is being done, not by me. It's being done by some incredible people just on their own. They're doing it. And I'm just, what I'm doing is I'm giving you the interpretation, what I'm seeing, what they are posting on social media. And the x-ray on this, it's showing that it is just basically too close to the heart. And he's looking, he's saying, oh, it needs to be pulled back. Unfortunately, he can't pull it back. He is now gowned in glove and sterile, in a sterile field, putting in another line in another baby. He can't do it. In addition, he knows that UVC line, or even though that should have been taken out, was still left in. That's the umbilical catheter one that's stuck in the liver. He knows he needs to pull that back too if he needs some sort of an emergency line. Now, we're getting on to 8 o'clock. Second shift is coming on with nurses. Even though it's an 8, technically, it's think of 8 p.m. to 8 a.m. The nurses show up at 7:30 to kind of get report and kind of get things started. So it's, even though it's an 8 to 8, they kind of start working at 7:30. And not only Lucy comes on, now she will be assigned this baby, but another nurse comes on, and she will be assigned another baby in that unit. And she is currently in the unit room 1, where Lucy is not, in between that 7:30 to 8 o'clock period, starting whatever her shift and starting whatever she is doing. And what we found out now, and again through that leaked document that was done, is that all of a sudden she is seeing something. I'm assuming she's seeing something on that monitor, or something is going on with that baby. We do not know what that is, but bad enough for her to look right into that registrar's face and say, do you think it's the line causing this? Do you think it could be near a vessel, in a vessel? You know, because we know that could cause an issue. We don't know what that registrar's response was. Again, he was gowned in glove in a sterile situation. There really was nothing to do, but he is aware sometime between that 7:30 and 8 o'clock something is going on. Now Lucy is entering the room at 8 o'clock, and she's looking at baby A, and she's going, oh my God, this baby's jittery. And that is classic sign of this baby as low blood sugar. And lo and behold, that baby was due for a blood sugar reading at that time, and it's either that lazy nurse didn't do it. Now, she definitely should have, without a doubt, or if she did it, she didn't document it, and probably for good reason. It wouldn't have looked good for her. We do not know. Now, again, this baby's jittery. It is a bad situation. This baby needs sugar. And they have already connected the line of the sugar line to this long line. Lucy and that lazy nurse do it together. They should, because you have to do it in a certain clean technique. And the registrar gives them okay to press that button to start, which it does. And that started at 8:05. This is 5 minutes after Lucy knows jittering, because this is truly an emergency situation. 15 minutes later, 8:20. Lucy notes that this baby is just grossly pale, and clear sign that would, to me, would be a sign of there's a cardiovascular collapse. Blood is not being perfused to this baby to wherever it needs to go. All of a sudden, the baby then becomes apneic, stops breathing. The heart rate now just goes down. That registrar panics. He runs over to this baby and pulls that line out. That's the only thing that this baby has to get more sugar. He's thinking that the line might have irritated, because they had noticed it on the x-ray, might have been irritating the thing. What could have gone on, and again, we don't know, is that the baby, it was just a coincidence. The baby literally just ran out of sugar, and it may not have been that line. So he took out that only source of that baby for that sugar. And you think by pulling that line out, the baby would have all of a sudden, okay, started to show signs of getting better or stabilization. No. In fact, it does the exact opposite. It gets worse. The heart just completely stops. The baby has to be intubated, and they have to put, that tube down it. Lo and behold, we find out there's clots in that tube, and that's clearly a sign the baby is clotting. On that monitor, they're seeing something called a pulseless electrical activity, and that's basically telling us that, yeah, the heart has, in that natural pacemaker that a heart has, it's sending out the electrical things. It's telling that heart to beat. That muscle cannot respond or will not respond to that beat, to that electricity, and contract. Now, this is so bad that this is one of those kind of odd arrhythmias that even if you would take a defibrillator and do it and send electricity in an external way, you can't start that heart. That muscle will not respond to any electricity, whether it comes from the pacemaker or if it even comes from the defibrillator. Another thing, there's wonderful, and I'm junior doctor, doesn't really know what to do. It's a first year. I don't think he's ever seen a baby crash like this. So what he does the right thing. He takes the pen and paper and he becomes the scribe for this crash, or we would call the code. During the code, basically things are going on, a lot of stress is going on. You're not going to be able to remember what you did during the code. So someone will stand aside and look at everything that's going on and write, just as a scribe would, what is going on, what medication goes in, and everything that is going on there. After that register intubates that baby, there is no documentation that something called a capnograph was used. And that's an important thing you want to have after you intubate someone or during a crash or a code. And that's just a measurement, is the tube putting out carbon dioxide? And that is going to tell us that, yes, more than likely the tube's in the right place. It's doing what it needs to do. You're getting in enough oxygen, enough that you can put out good enough carbon dioxide. Now, later on during the cover-up, Brewery comes around and puts a lot of pressure on the nursing manager to go and talk to that lazy nurse and say, yeah, capnograph was used, a capnograph. And she goes, oh yeah, Dr. Brewery, it was. There is no way that she would have known during this crash, because she was not at that incubator. What she was doing, and she was doing the correct thing, she was preparing the emergency medications for this crash. The person that was at that, where all this was going on with the resuscitation, was Lucy. No one asked Lucy. I wonder why, because I think the answer would have probably been no, the capnograph wasn't being used. Again, we don't know. And a golden rule in any medical situation: if it's not documented, it didn't happen. You can't come back and say that it happened. Now, Ravi finally comes tottering in, and he's noticing what's going on here. He decides, let's start pouring in medication. One of the medications called adrenaline that would jumpstart the heart. Well, the only IV access this baby has, again, is that UVC line that is stuck in the liver. So they're pouring adrenaline in, and it can't get to the heart. It hasn't been pulled back. Although Ravi seems to think, there's some kind of odd documentation that he does afterwards, and again, and that register does, that says, we may have pulled it back again. Who knows? I don't think that happened. Again, that adrenaline is just getting stuck in the liver infiltration, and it's not going to get to the heart and do it. And even worse, they pour bicarb in it too, and it's an important resuscitated medicine. It's preventing that baby from getting too acidic. But problem with bicarb, there's a certain formula it has, osmolarity. I'm not sure what it is, but it is very, very harmful to liver cells. So, and it ends up there's on autopsy there is a clot in the liver, and then again that's why Shuli is thinking that the death was probably a clot situation, that the baby, what we would call throw a clot. And basically, the resuscitation takes about 30 minutes and nothing works. It's sad. And, they call it, and the baby, unfortunately, is not with us here. So what do we think happened? And I'm just making a good guess, good guess. Shuli seems to think that because of the APS, antiphospholipid syndrome, that the baby threw a clot, and that just absolutely makes sense. And again, it may have thrown a clot to the brainstem or any other kind of major vital organ. And again, the clots would, because the baby's vessels are so tiny, it's a tiny clot, and that's possibly something that may not be picked up on the autopsy. Shuli and the defense is unaware that this mom has lupus and this could be a cardiac issue. So again, I would love to know if Shuli and his panel, if what their decision should be had they had known, and had we all have known that there was an obstetric history in that. Baby's low sugar. Good. This would be low enough to where the heart just says the muscles can't contract. The brain can't function to tell the baby to breathe. Again, we don't know and again, could the baby have a cardiac arrhythmia? The heart's not pumping correctly. The electricity is not working in the best way. Something's kind of going on here. Babies, we do know that there is a link between moms having lupus and babies having cardiac issues. Again, we will never know. A simple 12-lead EKG was not done on either one of these babies, and it should have been the first thing they did, or one of the first things they did when these babies were admitted into the intensive care unit right following the birth. Again, we don't know what happened. And it could be everything, all of the above, or it could be something else. It's a common knowledge. And rarely is death caused by one thing, unless you're hit by a bus. It's usually a cascade of events. This is going on here, this is going on here, covering up here. And it literally becomes a perfect storm. And that's usually what ends up being the end result of a death. It's a series of several factors, not just one thing, or that one thing was literally the straw that broke the camel's back. Again, we don't know what that straw is. Now, there's been some incredible things that are going on now, and they're forensically trying to figure out what is going on so far as Brewery has left a paper trail into what he's doing with cover up, and so Ravi has done too. So again, I will update you that may take a little while. I'm just trying to get all my ducks in a row before I kind of give you that information. Be aware, it is a clear screw up. They know it. They do not know that mom has APS or lupus until right after this baby dies. And mom, it looks like either the family member or mom's kind of tells them, I've got this thing called APS. And so what then proceeds further down the road is, we'll just say, on the level of Watergate. And again, like anything else, it is not what you do, it's the cover-up that's going to get you. And again, at this time, and they are clearly aware that this mom and dad would be owed quite a bit of compensation, and they're desperate. They're in the middle of a fundraiser. They're only halfway through this fundraiser. We need a new building. And this mother, rightfully, and father, rightfully, should be compensated and the funds, not only to wipe that fund out, but possibly even hit into the Countess of Chester, their bank account too. So again, take care. I'm on it. I'll have some other things that I'm going to post. And again, part 3 on the baby will be coming soon, but I can't tell you when. There's nothing that we are seeing that I would warrant an Agatha Christie novel. It's basically how they're able to scheme and do it. And the saddest part about this is that the inquest for this baby, mom and dad needed answers. And it was the brewery and company was able to forestall this inquest by an additional year. I'll take care. Bye-bye.